Good evening, everybody. I welcome you all to this webinar. The topic for the day is Acing seasonal infections with next generation sequencing. And we are so happy to partner this webinar with a very reputed institute and one of the most brilliant infectious disease specialists I have been fortunate to meet. To brief you on our journey, we at HaystackAnalytics have the vision and mission of making infectious disease diagnostics modernized and our healthcare ecosystem empowered with the latest technology in this field so that we never miss the detection of infections, so that we are ahead of the bug, and so that we can attain antibiotic stewardship through the same. This journey started out in 2019 and it has been quite adventurous and exciting. I think we have come a really long way, and all of that has been possible because of the support we received from various healthcare institutes and from doctors, just like today's speaker, who were brave enough to try this technology and to check for on our behalf whether an advancement that we claim of has been of use in the clinics. Could this achieve translational research? So, to see whether really in this spike of seasonal infections, next generation sequencing can be useful, we have with us today our chief guest speaker, Dr. Shareek P S, who happens to be an infectious disease specialist practicing in Trivandrum and the surrounding cities. He's a very renowned physician, has a very analytical approach because every time when I have a word with sir and the way I see him discuss a case, um, it sounds a very logical approach, and that probably the way they work in the clinics, it becomes very imperative that the allied sciences provide them with the necessary artillery to reach a definitive diagnosis. Sir has been a consultant in infectious diseases at SUT Group Trivandrum with over 15 years of clinical medicine experience. He's an expert in inpatient and outpatient infectious diseases management and has managed infection control programs as well during various international accreditations. He has completed his MBBS from Government Medical College Thrissur and his MD in Internal Medicine from Stanley Medical College Chennai. He has a fellowship in infectious diseases from Apollo Hospitals and then underwent intensive clinical training in India and Saudi Arabia. And currently, he's registered with the Travancore Cochin Medical Council. Sir has a lot of accolades to his name. He has contributed significantly in his field of practice, and his areas of expertise are tropical and ICU related infections, hospital acquired infections, infections in the immunocompromised. He has been a champion of antimicrobial stewardship program and in diagnostic stewardship, and has also entailed a lot of academic activities. Sir has been one of the earliest adopters of this technology. When we had presented it to him way back, I think it has now been more than 2 years. Sir has experienced it in various clinical scenarios, and he has been kind enough to agree to present his clinical experience with this technology in various spectrum of infections as and when suspected by him, and how this has helped him achieve a better patient outcome. So over to you, sir, to share your experience and give us insights about your journey with sequencing in infectious diseases. Thank you.
Thank you, Dr. Mahua, for those kind words. I'll just share my slides. My slides, you can see.
Yes, sir.
Okay. So will be. So I was introduced to NGS somewhere in 2023. So from the clinician's point, being ID physician, I see everything with a pinch of salt. So I was very skeptical to accept this as a this thing. So I just thought it's just another fancy test. By that time, we were fed up with a lot of this manual multiplex PCRs, which gave nonsense results. So we were just resorting to our clinical skills and plus our culture. That's it. So we had no other way except gene expert. We had no other reliable test. So that's how this was the first my interaction with NGS. So this was a 56-year-old female presented with fever, myalgia, different pains, abdominal pain, dyspnea, all those things for 2 days into ICU. So her CT abdomen was showing pyelonephritis, but cultures were sterile. Routine workup showed scrub typhus was positive. So now the confusion was whether it is pyelonephritis or the scrub typhus is it false positive. So that was the confusion there, what to do. The patient was on meropenem and doxy empirically. Patient improved. 2 days time, patient improved. So is it pyelonephritis or scrub typhus? So what shall we do with the antibiotic? Now CT is showing pyelonephritis, but scrub typhus IgM is positive. So I was a bit confused. So I thought we'll just have a try with NGS. This was the scenario. Leukocytosis was present, platelet was normal, 2D echo was normal, LFT RFT was normal. Now, this was the first shocker for me. It turned out to be scrappitis. The blood NGS showed scrappitis. So that was my first thing. I thought this has something to do with this. So that was the time when I started noticing that this is not a bogus test. This has something. So this was my first experience with this one. So I stopped the meropenem, discharged the patient with doxycycline, patient improved, obviously, because we know that it is scrappitis. Now, this was another test where this was basically lymphocyte dominant meningitis. So, was thinking of starting with ATT. But then we thought that we'll just do an next generation sequencing because a gene expert was negative. Turned out to be aspergillus. We went back to the history. The patient had an aspergilloma for which the surgery was done some 1 year back, but no antifungals was given. Obviously, no need of any antifungals. But this patient turned out to be aspergillus in the CSF. The patient died. We started the body also, the patient died. This was the second thing. So this is apart from the normal things, this adjunct test helps us in many ways. In many of the scenarios, it helps us. Okay. So this was my second shocker, where aspergillus in the CSF, and it correlated as now we had some culture negative SPPs. I thought we'll just have a try and started getting odd bugs like Nordella oligomobilis. I was hearing for the first time. When you do with NGS, you have to do a lot of researches. Okay. So because most of these bugs you may not be even heard of. So Nordella, I was not very sure. So I had to refer and then unfortunately the patient died, but we got. Then the peritoneal right to show some intermediates, bacterium, periodal. The common combination there, you get the same thing for peritoneal fluid. This thing, Streptococcus intermediate, bacterium, and pivotal. All these three will be seen in the same group. So this was one tissue where this was again a little bit confusing case. This case was from outside. This was a post the same some arthroscopy induced surgical site infection. So what happened was that we had did all the investigation and that histopathology was showing granuloma. So we were thinking of could be an NTM. Thought we'll try with NGS and Mycobacterium abscessus was detected in that. The culture turned out to be negative. But this was another thing where we got Mycobacterium abscessus. And these are some of the scenarios which I saw. And in a BAL sample, we started getting mycoplasma by that time. So mycoplasma was an unknown entity at that time because we don't know there was mycoplasma or we have read in the books, but we are not detecting it. But once this biofire came and we started getting mycoplasma, and the same mycoplasma we are getting in the NGS. So what dictum what was that? If the H1N1 is negative or the COVID is negative, then you go for the BAL. When you go for intubated ET sample respiratory secretions, you do this thing. Many times we get mycoplasma. It's very helpful for us because we can stop all the rest of the antibiotics. Patients would have been with meropenem, ticagrelor, all those things. So we can stop all those things and continue with the mycoplasma treatment with doxy being the preferable. So this basically is very useful tool for the respiratory sample as well. And then recently I had a case where yes, culture negative, it's basically useful more with the culture negative. Culture negative CABG surgical site infection. Very tricky scenario. Started patient with Miro and TG cycling. Patient improved, but then it was not improving. Again, patient came back and then we did a repeat tissue cultures. Everything was negative. We sent a sample. It showed Mycoplasma hominis. So initially, the problem here is that it detects many things, and we may not be aware of all these things. So initially, I thought it could be a contaminant or something nonsense one. But then I referred. Actually, Mycoplasma hominis is an organism which can produce surgical site infection in the CABG. And then I was shocked. Again, I had to go read and just start the treatment with fluoroquinolones plus doxycycline. Patient improved very well. Patient has improved very well. We are actually writing a case report on that mycoplasma hominis. Otherwise, wouldn't have been detected at all. Non-tuberculous mycobacteria, we normally think of in CABG, surgical site infection, we think of non-tuberculous mycobacteria. That's fair. But this, in that, the tissue will show granuloma. But here, what happened was there was no granuloma, no culture. So we thought it could be some anaerobes and kind of that stuff. But it was mycoplasma. So all these cultures will be negative. So all the sterile scenarios, there is a bug behind that. Unless we detect that, we'll not be able to treat properly. If I have missed that mycoplasma, I would have lost that patient. For example, if you go back and see everything, each and every case I would have missed. If I didn't do NGS, I would have missed it, right? So no way we will be thinking of aspergillus in the CSF. No way we will be thinking of nodella. No way we will be thinking of mycoplasma. All these odd bugs is the one where it helps us, right? So the challenges of the existing technologies, you have the two things, one the PCR methodology and the other gold standard is blood cultures or cultures, right? Problem is the culture is time consuming, poor sensitivity, and prior empirical therapy conforms with the results, low clinical sensitivity, especially for the fastidious organism, and poor guide to pathogen diet. Many a times it will be culture negative. All these scenarios will be culture negative. You're not able to get that. And PCR technology, again, PCR technology is unless we do it in an automated thing, the manual thing, it depends on the quality of the lab. Many a times there will be false positive results which confuse us. Many a times it will confuse us. Especially this multiplex PCRs confuse a lot. I had scenarios where CSF was showing no evidence of meningitis, but the CSF in the multiplex PCR showed Candida, Pseudomonas, all those things. So very difficult to interpret all those things. And the small detection range and is unable to test unknown pathogens. We have to know what exactly we are going to check. That is a problem with the PCR. When the culture, it's okay. It may grow anything. But PCR, you need to have the specific primer. You have to think of this disease, then only you can get that. Otherwise, we will miss. And you need the specific primer design. That's the problem with the PCR. Now, why NGS is that basically it's an open platform. You can detect bacterial, fungal, anything, right? Any bacteria, any fungal. You don't need to have any primers or think of this thing, probably Brucella, probably this thing, probably that. There's no need of probabilities. It just detects. Then data-driven diagnosis without premonition of the suspected species. We need not suspect the species. Otherwise, we have to suspect that. So unbiased and untargeted, so benefit from any DNA sequence information within patient specimen, right? And recent developments in the sequential technologies indicate that it will be possible to sequence even larger amount of DNA in the shorter time. No need for any primer specific design. That is the most advantageous thing. More effective in detecting co-infections. That is very, very important. Polymicrobial. Specifically, anaerobes will be there many times in the empyema. So that polymicrobial, if we miss, the patient will not improve. And less affected by the empirical therapy. That's one other good thing is that it is less affected by the prior empirical therapy. It's accurate, comprehensive, and rapid. Can detect thousands of fragments in a single test, thus reduce the number of tests and detection time. So this is in broad what is the advantage of NGS when compared with them. Now let's go just do a little bit of a literature review with this. So this was one study which was this is a small study, not mass scale studies. This was one study which said with done with the septic shock patients, where the blood culture positivity was compared with the NGS, where it was 33%, 33% at the sepsis onset, whereas in the NGS sequencing, it was 72%. So there was a significant increase in that. On the whole study period, blood culture positivity was just 11%, but the NGS positivity was 71%. So probably it showed a good results when compared with the blood culture in septic shock. And the same, if you see with sepsis, not in shock, but in the sepsis, if you see, there was a positivity of NGS and blood culture had significant difference, 62% and 14.5%. But in my experience, blood, we have a little bit trouble with the blood. We are not able to detect this kind of this thing in our blood. Probably we have a lot of other areas like your CSF and your bile, your tissues, your urine samples. All those things detects more when compared with blood, we had a little bit of trouble. Sensitivity is a little bit low when compared with uh, blood culture. So this was the, but this is what study says. Then you had the compare with the orthopedic infections, all those things, it performs very well. Actually, it performs very well. And this study also showed that uh, this had a very high success rate to detect the pathogens. For example, in the NGS, it shows 73% and 59% in the traditional cultures, respectively. So difficult to grow organisms such as slow-growing anaerobe bacteria was better detected by NGS compared to the traditional culture. For example, I had that Mycobacterium abscessus septic arthritis. So that was detected by the NGS. So this is the use with this kind of NGS because you don't need to have do separate tests for each and everything. What are the advantages and the disadvantages with NGS when compared with the microbiology detection? As I told earlier, benefits of the culture is that widely available, easy, cheap kind of stuff. And NGS, the advantages are higher sensitivity and specificity than culture, decreased time for detection, and you have the genes as well. You get that. That's very, very important compared with the previous era because we are dealing with ceftazidime-avibactam where you need the genes to detect what combination we should give. So that is also very important and that we can detect from the NGS. The problem with the NGS is that may be confounded by presence of post DNA, requires highly specialized equipment, trained technicians, and bioinformatic experts in is needed. That is the problem with that. And another problem is that you have to know what is a colonizer, what is a pathogen. That is very, very important. Even I have missed many a times. I thought it's a colonizer, but I went back and thought and read back. I felt it was a pathogen. So because all those things, what you felt as a pathogen, I mean, colonizers could be a pathogen. So you need to know you need to know when to say it is a contaminant or colonizer or when it is a pathogen. You have to be very careful, and you will be daily you will be updated on a new bacteria which you have never heard. That's a funny part with the NGS type, right? And this was another study where they have done with 99 patients with NGS and the blood culture. So here the blood culture positivity was just 13%, but NGS positivity was 65%. They say with the blood culture, but that's where we are a little bit worried because our blood culture results are not up to this mark as per in our experience. Now, this is one we did with, this was one study which was done with the bronchoalveolar. Again, compared with the culture, your metagenomic NGS diagnostic sensitivity of 88.89 and the specificity of 74.07. And that showed a gross difference when compared with the cultures and even the PCR, right? So what are the samples we sent? So blood, we can try in the sepsis cases, specifically in the septic shock kind of stuff, can try with the blood. CSF, and then blood can be sent for our new fever panel. That is one thing which I'm waiting eagerly, specifically when it compares with when I deal with this endemic fever. Many times cultures will be negative. Even you take four bottles, 40 ml, only 50% of the time grow. Rest of the things you need to wait till 7 days to get the serologies, your lactose, all those things you need to wait for the serologies for 1 week. So the first week is totally blank for a clinician, except in endemic fever. If you do the blood culture positive, that's okay, good, well, good, but only 50% of the time. Only second week, you are going to have your lepto IgM positivity or scrub IgM positivity, where you do it in the blood and you get that. Suppose if has a good sensitivity, believe me, that's going to make a huge difference in antibiotic stewardship. Because most of the time, what happens is that first 4 or 5 days, patients will be going with high-end antibiotics like Mirotico, Doxy, that is the cocktail which most of the ICUs will be using. But if you have this one and suddenly you pick something, lepto, you can immediately come down to ceftriaxone or penicillins or ampicillin. So this is going to have, I'm eagerly waiting for this because it is going to have a huge impact in antimicrobial stewardship because antibiotics are being used mostly for the acute febrile illness in the less than 5 days time where you don't have too much of diagnosis except for the blood culture. Then CSF, it shows high neutrophil count because CSF we don't have. Now we have started added virology into that. But basically CSF, in case pyogenic, you do that. And pleural fluid, if neutrophil predominant exudative effusion has excellent pick. Satic fluid again has excellent pick. And BAL has excellent. So these are the 3, 4, and tissues. You can have tissues from any of these areas. You can have tissues, and you have your urethric ward. When you put a DJ, you take the urine and send for NGS. Those are the things where it helps us to titrate antibiotics a lot. Otherwise, all these patients would have been going with meropenams for 4 weeks or so, most of the time. Where I can change to clindamycin, oral metronidazole, and shift the patient to oral metronidazole or clindamycin. What is the cost factor for the patient? Huge factor. Because if there is an empyema, you're going to treat for 4 weeks. If you have a abscess, a renal abscess, liver abscess, you're going to treat for 4 weeks, right? So 3 to 4 weeks, you need antibiotics. So what will you give if that's culture negative? You're going to give some meropenem, teicoplanin kind of stuff for 4 weeks. What is the cost involved? Huge cost. So when compared with the cost of the NGS, I strongly believe if you can get this and get the bug, you can change to oral metronidazole, clindamycin, amoxicillin, or whatever simple things you can do. And huge cost saving. That's what I felt that I'm about to discuss with Dr. Mahua about the cost effectiveness of NGS. That is what I've been planning when we are able to meet next time. I was going to ask her whether we can do a study on the cost effectiveness of NGS. That's very, very cost effective, specifically in the abscesses kind of stuff, which is really cost effective. Otherwise, all these patients would have been going with an IV antibiotic for next 3 to 4 weeks. So this is what my experience with this one, and this is what our experience, our scenario in our hospital. From 2023 we started, and right now till May 2025 we had total 1,152 samples, and most of it we did with net 441. Respiratory we did with 115, and this NGS swab. I mean, like your swab for nasopharyngeal swab detection. That is another good thing, because you have COVID, you have all the flu panels, all the common things are there, and you can detect it early and start with or stop antibiotics or whatever be. That's also very useful. So tissues we had many, pus we had many, urine we had, especially from the theater. All the theater samples probably we are sending it right now and keep in the. What we do is that we keep all the samples in our microbiology. If the cultures are negative, we'll send for NGS so that the cost effectiveness will be there. Not send for everything for the NGS. We just keep in the microbiology lab from the theater samples. And once the cultures are negative, we send for NGS. That's how we do. And this is the distribution, organism distribution in our hospital. Basically, you had bacteria, mostly 740. Yeah, that's what we aim at. And you had fungi of 29 and the viruses of 53 we detected. And viruses mostly we detected from the nasopharyngeal swab and the BAL samples. Now, this is what all these organisms we have detected in our hospital. Your Elizabeth Kingia, Candida, or Scotamia, all those things. Leptospira it was detected. Gonorrhea we have detected. And then this is the diagnostic resource burden. This aerobic, all those things will be 22, 24, but anaerobes will be 96. And we had the difficult to culture was 11.3%. This is the pie diagram of this one. Microaerophilic had around 7.5, and those with require the specific nutrition requirements, we had 8.1. And Candida auris, like misidentified organisms, be 2%, and unculturable, it was never being cultured, had 5.5%, and gas requirement. For example, in leptospirosis, you need special requirement for the culture to grow. Those kind of stuff had 0.8. So basically, it detects most of the non-culturable organisms, which helps us in reducing the antibiotic. Come to an exact etiological diagnosis. That's very, very important. You come to an exact etiological diagnosis and you discharge the patient second day. In case of this is strep typhus, you discharge with doxycycline. You need not continue with the antibiotics. Second day, third day, you stop antibiotics, discharge. So that's how we have been going on. And this is how the fungal, this thing, basically you have all the candida, all the malacesias you can detect, Tryposporin, Asahi, Saccharomyces, all those things. Then this is our Aspergillus group. This is the mold, Aspergillus, mucor, all those things can be detected. And these are special temperatures. The problem is that you need special requirements, special incubators for the cultures to grow, right? And then you have the incubation period varies. For example, in yeast, for example, in Candida is 24 hours, but for mold is 10 to 14 days. Sometimes in Aspergillus, it may go a little bit longer time. Mucor may grow a little bit early. And then something require a special media. For example, chrome agar for Candida species, we need chrome agar, lipid-rich media for malassez. There are special microbiological requirements, or those things can have to be looked for. Special culture methodologies we need to adopt. Now, the identification challenge, microscopy, basically, you very, very difficult. You need long turnaround time and you need a special intense skill to detect the fungi. That's very difficult. What I do practically is that I do with when I have a difficult thing, I do with a maldito, right? I do with a maldito or I'll do with an NGS. That's how we do that. So that's how we identify what fungus is that. Identifying the fungus is very, very difficult most of the time, unless you are a very expert with this. And then automated IDST, drug sensitivity, right? For example, culture-dependent confidence in speciation at query. For example, Candida auris, I said, being wrongly misidentified as Candida hemoluni. See, when I was doing my studies, when my fellowship in Apollo, I did a paper on Candida hemoluni. So most of them were Candida hemoluni, and actually I have published a paper saying that Candida hemoluni is very, very common. But then we realized that it's not Candida hemoluni, it's Candida auris. So that's how I have learned that hardware. It was not hemo only, it was candida, or this later turned out to be candida. It was misidentified by the white tech. So this is a problem. You have misidentification. All those things can be sorted out with our NGS system. So to summarize, NGS when compared to culture has a high pathogen identification, specifically in septic shock, sepsis, bone and joint infections, and bowel sampling. So turnaround time is basically very low, very low. You can get the results easily, right? And genomic level pathogen isolation can be done. Less volume of blood is needed when compared with the blood culture. So, and most important, in culture negative scenario, it is worth a try, because once you get the bug, it will be entirely different treat. Specifically when you have need a prolonged therapies, prolonged therapies, like 4 weeks therapy. Many times we need a long-term therapies, like spondylolisthesis. You have some kind of osteomyelitis, where all those things can be done. So this is the advantage, most important advantage with the NGS is that you need not decide what could be the pathogen, because that's the problem with the clinician. Always ask, everyone asks me what test to send. For that, I need to know what am I suspecting, especially when handling with the PCR. That is a problem. We need to know what am I suspecting. Then only I can send that specific PCR. But here it's not needed. But the problem here is that virology part, we are not, this NGS is not very strong. The bacteriology is strong, mycology is very strong, but the fungal part, I mean, the virological part, upcoming, but not up to that level. So that's where the lacuna is with NGS, and probably sensitivity has to be more studies we need in the sensitivity, specifically with the blood. That is the negative points which I have seen with the NGS. Thank you.
Thank you so much, sir. This was so brilliantly summarized, touching every point. Uh, the clinical applications, the positioning of the test, the cost effectiveness, some of the current limitations, which I'm sure, sir, with your help and guidance, we will be able to resolve.